Surgically induced IOP elevation. Conventional surgical procedures such as cataract extraction are occasionally associated with transient IOP elevation. Similarly, laser surgery, including trabeculoplasty, iridotomy, and posterior capsulotomy, may be complicated by post-treatment IOP elevation. Although the IOP may rise as high as 50 mm Hg or more, these elevations are usually transient, lasting from a few hours to a few days. Other procedures, including vitrectomy and penetrating keratoplasty, PKP, may be followed by a sustained increase in IOP. The exact mechanism of the IOP elevation is not always known. However, the presence of inflammatory cells, RBCs, debris, pigment release, mechanical deformation of the trabecular meshwork, oxidative damage, and angle closure may be involved. Agents used as adjuncts to intraocular surgery or postoperative treatment, e.g., corticosteroids, may also cause secondary IOP elevation. For example, the injection of viscoelastic substances into the anterior chamber may result in a transient and possibly severe postoperative increase in IOP. Cohesive viscoelastic agents, especially in higher molecular weight forms, may be more likely to cause an increase in IOP than dispersive viscoelastics. Postoperative IOP elevation, even over a short period, can cause considerable damage to the optic nerve in susceptible individuals. Eyes with pre-existing glaucoma are particularly at risk of further damage. Thus, it is extremely important to monitor IOP soon after conventional or laser surgery and to consider treatment with IOP-lowering medications at the time of surgery. If a substantial rise in IOP occurs, IOP-lowering therapy may be required, including the use of topical B blockers, A2-adrenergic agonists, or carbonic anhydrase inhibitors. If postoperative inflammation is present, prostaglandin analogues may be deferred until the inflammation has resolved. Paracentesis with release of aqueous fluid, and possibly viscoelastic, can be used to rapidly lower the IOP if it is substantially high. Persistent IOP elevation may require filtering surgery. The implantation of an intraocular lens, IOL, can lead to a variety of secondary glaucomas, including uveitis glaucoma hyphema, UG, syndrome, secondary pigmentary glaucoma, pseudophakic pupillary block, see Chapter 10. UG syndrome is a secondary inflammatory glaucoma classically caused by chafing of the iris or ciliary body by a malpositioned or rotated anterior chamber IOL. It is characterized by one or more chronic inflammation, elevated IOP, recurrent hyphemas, cystoid macular edema, iris neovascularization. This condition can also occur after implantation of a posterior chamber IOL in the ciliary sulcus or one that is suture fixated to the iris or sclera. Implantation of single-piece acrylic IOLs in the sulcus is a particular risk factor for this condition and should be avoided. Gonioscopy and ultrasound biomicroscopy may be helpful in revealing the IOL's exact position in relation to the iris and ciliary body. Persistent or recurrent cases often require IOL repositioning or IOL exchange, which can be technically challenging because of POS-CBLE synechiae and or an open posterior capsule. This syndrome may be mimicked in patients with neovascularization of the internal lip of a corneoscleral wound, which may result in recurrent spontaneous hyphemas and elevated IOP. Laser ablation of the vessels may successfully resolve these cases. Secondary glaucoma is a common complication after PKP and occurs with greater frequency in aphakic and pseudophakic patients and after a second graft. Wound-induced distortion of the trabecular meshwork and progressive angle closure are the most common causes of glaucoma after PKP. Attempts to minimize these changes with different-sized donor grafts, peripheral iridectomies, and surgical repair of the iris sphincter have been only partially successful. Alternative procedures, such as lamellostromal or endothelial grafts, may have a lower risk of elevated IOP. Long-term use of topical corticosteroids after PKP is another potential cause of elevated IOP and secondary glaucoma in these patients. Surgical interventions to treat glaucoma after PKP are associated with an increased risk of graft rejection and failure.